Good morning, PTO Nice Daily Show. How's it going? Welcome to Clinical Tuesday. My name is Dr. Lindsey Hughey. I am one of our division leads at Extremity Management. Excited to be with you all on a Clinical Tuesday. It's been a little while. Today, we're going to chat about what's best for CTS. So, I will unpack what is CTS. So, what is carpal tunnel syndrome? What symptoms will our patients present with? And kind of who it affects. And then we'll spend most of our time talking about the treatments that are available. And then what does the literature say about these treatments and their efficacy? And then we'll see how they compare to one another as per the research. And you're going to see a lot of heterogeneity here. And then I want to propose at the end a PT first and only approach because we can do better here in our carpal tunnel care for our humans. So, first things first, what does this human look like? What does this patient look like? Well, they're going to complain of numbness, tingling in these first fingers. They might even have anesthesia, so like lack of feeling here. These symptoms tend to worsen at night when we're kind of curled up in that phalanx position, right? That's often a positive test for these folks because they are decreasing that space that canal of where the median nerve travels and feeds those fingers. It is the most common nerve entrapment syndrome we'll see in the extremities. When we look at epidemiology studies, you'll see that this affects 0.3 to 3.8% of the general population. And then it will affect females more than it'll affect males, about 2.5 times more. It's a condition that sucks because it wakes you up at night because of that numbness, tingling, and if you've experienced it firsthand, I'm currently going through a bout of it myself. It sucks, and it wakes you up in the middle of the night. It makes gripping objects challenging. If it gets worse, your IADLs and ADLs just start to become difficult. Some predisposing risk factors to developing this condition are having obesity in your history, arthritis, diabetes, hypothyroidism. It affects our pregnant folks due to that increase in fluid volume. If there's a family history of diabetes mellitus, you might be predisposed to having this as well, and or rheumatoid arthritis. Consider all of these things as a whole, excluding pregnancy. We're dealing with a lot of metabolic disease coinciding with our carpal tunnel symptoms. The underlying pathophysiology is not clearly understood. So while we understand the predisposing factors, we don't really know what is causing the symptoms. But what is understood is theorized is that ischemia around the median nerve due to edema um, and pressure is being formed around that nerve, which is causing those symptoms. And if left long enough, we not only see sensory disruption, we actually start to see motor loss. And that's when it becomes more serious, right? When we see latency in our nerves and then an ability to then activate musculature in our hand. Some predisposing factors to developing this condition for our humans are prolonged and repetitive flexion extension of the wrist. Think about like our typers or being on your phone for prolonged periods in this flex position. We see repetitive flexion extension in our factory workers. So if there's a combination of not only that repetition, but high force hand grip motions with flexion extension, again, predisposition to having this. And trauma can also lead to this condition and some underlying infections and neuropathies. So that's kind of carpal tunnel in a nutshell, who it affects, some underlying risk factors, and then some predisposing factors. What are the solutions? Like, what do we do to help this condition? Well, you are really going to see a very wide buoy here of what is recommended. So we see corticosteroid injection being recommended, and the theory here is that helps decrease edema around the nerve, which increases, in theory, space then between that carpal tunnel and the median nerve. NSAIDs are also recommended, and it would work the same way. We're decreasing inflammation to help create space around that nerve. We've even seen extracorporeal shockwave therapy being used more recently. And then in very recalcitrant cases, where we start to see progressive sensory and motor loss, so like dipping in that thenar eminence because of atrophy, surgery is recommended. So this is for folks that have had like positive EMG studies where we see axonal damage in the median nerve. And this is done by either an ortho surgeon or a hand surgeon. It's a relatively minor surgery where they cut that transverse carpal ligament or the flexor retinaculum to create some space for the median nerve. And then there's physical therapy. And you'll see, I'm going to unpack the widespread physical therapy treatments as well. But before we dive into the physical therapy treatments, I do want us to recognize that the NSAIDs, corticosteroid injection, and surgery, they all come with some risk, right? If you are taking NSAIDs for a prolonged period, you're at risk for GI bleed. If you are doing corticosteroid injection, right, there is risk for possible infection at that site or discoloration at that area. Surgery, we know, is always risky in regards to infection, iatrogenic things that can happen, and we still see people having hand pain after this surgery is done and still having symptoms. From a physical therapy perspective, what's our role and what has been shown to be helpful? Well, here it's very widespread. Manual therapy. So, manual therapy specifically to soft tissues where that median nerve innervates. So, that could be pec, that could be bicep, that could be our pronator quadratus. So, going all the way down the forearm and then working into the hand. It could even be a little more proximal, like our scalenes. Carpal bone mobilization is advocated, tendon gliding exercises, median nerve, sliders and gliders. There's splinting over the counter to keep the hand in neutral while you sleep so you don't compress that tunnel. Education on just ergonomics and minimizing some of those repetitive actions that cause symptoms. Modalities are also been used in the treatment of this, such as ultrasound and electromagnetic field therapy, laser therapy, and time domain for physical therapy in the literature is anywhere from 3 sessions of 30 minutes of manual therapy to up to 10 weeks, where it includes a mix of our hands-on soft tissue work and neural mobilization. But what is actually working, right? That's a big list. And are we uniform in our use of these things as a profession? And the answer, short answer is no, we aren't. But let's pause about our profession for a bit and let's just talk about how are all these treatment options, so surgery, corticosteroid injection, and physical therapy shaking up in comparison to one another. So I want to just highlight the most recent kind of to the most most recent to like what we've known for some years. So just in 2024, we had a Cochrane review come out comparing surgery to corticosteroid injection. And both showed benefits in improving pain and function, um, definitely in the short term. But when they compared them to one another, there was really no superiority of choosing one or the other. So that was 2024. In 2023, we had a systematic review from the Asian Journal of Surgery comparing physical therapy and local corticosteroid injection. The conclusion from this study was that the evidence, when they compared the two, did not suggest that that local corticosteroid injection brought more benefits than doing PT when they looked at functional improvement and pain. There was a superiority in the corticosteroid injection for distal motor latency in the nerve and then muscle action potential. There was a slightly significant improvement there. In 2022, a systematic review and meta-analysis from the International Orthopedics was published, and they looked at physical therapy specific interventions, where they looked at manual therapy effects on pain and function on nerve conduction studies for carpal tunnel syndrome. And what they found is manual therapy interventions that included both soft tissue massage and neurodynamics, both passively and actively, helped with not only pain and function, but we saw nerve conduction being impacted here. We have a 4-year prospective study that exists that compared surgery and physical therapy. And what's interesting about that is they compared only 3 sessions of manual therapy, physical therapy for 30 minutes with surgery. And what they did is they followed these folks for 4 years to see how did it pan out for pain and function. They did not look at motor latency or nerve function. But what they found is they had the same outcomes. So this was 2020 study, prospective. So comparing surgery and PT, not very different. So kind of starting to beg the question, like, is this surgery really necessary? And it also begs the question, is 3 sessions of physical therapy enough? In 2017, we had an RCT come out where we were comparing manual therapy, physical therapy with electrophysical modalities, right? Because I told you there's other things like laser and ultrasound therapy. How do they pan out? Well, we see that both of these actually had a positive effect on nerve conduction, pain reduction in the hand, functional status, and subjective symptoms. We did see a superiority, though, in pain reduction and subjective symptoms and function in the manual therapy group. So it favored manual therapy over our modalities. Another RCT I want to share with you, and then we'll kind of unpack what this all means, is that we compared other interventions, manual therapy interventions, which were, not manual therapy, active interventions, tendon glides and nerve glides. So things the patient can do. So not even putting our hands on this patient, tendon glides versus nerve glides. This was in 2011, so a little bit older study, but just want to kind of share where we've come from and where we're headed. Well, what we saw is that when you, this was 3 groups of folks where every group got paraffin and splinting, because splinting is kind of a gold standard to keep that wrist in neutral. And then they compared a group that got those things with tendon glides and another group that got nerve glides. And they saw that actually all groups got better with these interventions, but the tendon glides had a superiority in pain and function. So we see the evidence kind of as a whole, as it stands. And I want us to kind of reflect. We see all of them helping to some degree, but our ones that are a little more invasive, our local corticosteroid injection, right? And our surgery, when compared to one another, right? We see them both improving. But when compared to physical therapy, manual therapy, we actually see a little bit superiority, especially when manual therapy is involved. We see a widespread use of different types of manual therapy and dosage used in our profession. And so I would love to present kind of a dream of what a PT first and only experience might look like, right? Because PT, there aren't really side effects with going and opting for physical therapy care, right? All we see is reduced pain, right? Improved function. And when compared to very long term, it our outcomes look the same when compared to surgery. So let's stop going under the knife for this. Let's start having more inclusive care in our physical therapy, in our manual therapy, and our active interventions. Let's dream of doing manual therapy that consists of soft tissue, right? That works wherever that median nerve traverses, right? And we see impairment in that patient, right? The pecs, the biceps, our pronator quadratus, right? Working into our hand that works the carpal bones, right? If they have some stiffness, that gets after not only neuromobilization, but also tendon glides, because tendon glides help create a pump in that tunnel and help shift fluid, right? Versus opting for that NSAID or corticosteroid injection. Let's let our own body's movement medicine and blood pump heal that. Let's also add in our splinting, right? At night, make sure they're wearing an over-the-counter splint to modulate symptoms. Wear it during the day if needed. Also consider our pregnant and postpartum patients. They need care not only before, like during their pregnancy, but after, to make sure that fluid shift and carpal tunnel symptoms go away. Include education, right? That educates about ergonomics and change in position, that you're not always in this flexed position that decreases space and blood flow to that nerve. Imagine if we didn't just do 3 visits, right? Imagine if we did 10 weeks of therapy, 1 to 2 times a week. Because when we look at the evidence of when manual therapy is superior, we see more time has been done, more visits to that patient. So we can do better in our visits and in what we offer in care. And then, just as an aside, think about the whole human, right? We might have to go up into the cervical spine if symptoms are bilateral, right? We often see some correlation to that lower cervical dysfunction. So don't forget about working on our lateral glides, right? And doing things that open up that space centrally. We have quite an opportunity to do better in this space and not run to surgical interventions and our injections. I want to leave you with one final pearl, and then we'll call it a day for Clinical Tuesday. Nerves love space and they love movement and they love blood flow. One of our favorite treatments that we present in our extremity management weekend is a rehab EMOM that we call a nerve bath, which is it involves three things. Minute one, you pick a cardiovascular activity for your patient that they love, right? Maybe it's the UBE, maybe it's the new step, maybe it's just walking quickly or the assault bike. What psycho likes the assault bike? Alan. Anything that gets their heart pumping. And then minute two, do median nerve sliders and gliders. And minute three, get after your tendon glides to create a pump and or some other impairment. Maybe it's wrist extension, maybe it's wrist flexor extensor weakness. But do that and do 3 rounds to start and see how your patient does. You're going to hear things like, oh, my hands never felt more alive, or that anesthesia is reduced, right? Or that numbness tingling has gone down. They can grip objects better and test, retest, right? Test their grip strength again. That's a really powerful treatment that readily becomes an HEP to manage symptoms. When we look at the state of the evidence, it is all over the place, but it's an excuse to claim heterogeneity as a reason to hop into CSI, corticosteroid injection, or surgery too soon, right? And even in our own profession, there is widespread and divergent treatment. Do less better, but do it for longer, right? Make sure that we're getting time for these patients. 8 to 10 weeks. This isn't a 4 to 6 week deal. PT first and only for for carpal tunnel syndrome is really the way going forward. If you want to learn more about carpal tunnel syndrome, other hand and wrist conditions, the upper quarter, lower quarter, all in one weekend. Join us on extremity management course. Our upcoming courses, we have Davie, Florida coming up October 19th and 20th. Assuming it's safe to go there. Our hearts, by the way, are with people and prayers that hurricane will just pass. But our plan is to be there in a couple weekends. And then October 26th, 27th, we'll be in Paoli, PA. I'll be going to that course and watching Cody do his thing. So join us. And then November 2nd, 3rd, Midwest City, Oklahoma. Join us. I hope to see you on the road. And thanks for letting me go a few minutes past 9:15. Happy Clinical Tuesday, everyone.